38-year-old woman is evaluated in an inpatient gastrointestinal step-down unit for a 3-day history of progressive skin yellowing and dark urine. 3 months ago, she underwent an extensive small bowel resection following an acute mesenteric ischemic event, leaving her with approximately 45 centimeters of residual jejunum anastomose to the transverse colon. Since her surgery, she has been completely nil per ostomy and has relied entirely on centralized continuous TPN infused via a 10-volt subclavian catheter. She reports no abdominal pain, nausea, pruritus, or changes in her ostomy output volume. She has no prior history of chronic liver or biliary tree disease and takes no other daily prescription medications. On physical exam, her temperature is 98.2, heart rate 74, respiratory rate 14, blood pressure is 118/72. Scleral icterus and generalized jaundice are clearly visible. Abdomen is soft, non-tender, non-distended without palpable organomegaly or shifting dullness. Central line insertion is clean, dry, and intact with no surrounding erythema or warmth. Neurologic examination is unremarkable with no signs of asterixis or altered mental status. Initial laboratory evaluation is notable for total bilirubin of 5.8 and direct bilirubin of 4.2, which of the following is the most likely diagnosis. So this is an interesting presentation, and there's some important history components that are going to be relevant. So this patient has a central catheter from which she's receiving TPN. So if you're not familiar, TPN is just a way for patients to get nutrition, and it's typically given through a central line or a PICC line that goes towards into the superior vena cava and essentially gives nutrition. And it has all the nutritional needs covering fats, proteins, carbohydrates, and it's supposed to be an alternative for patients who cannot receive enteral nutrition, so through the mouth and through the GI system. And so this essentially bypasses it and still allows for the nutritional needs to be met. And there's some things that are important complication-wise, infection being one of them, but that's not really what we're seeing here for a patient that's not febrile and having no real complaints at this point. The only thing we're seeing here is that there's some jaundice developing with skin yellowing and dark urine, and we have this elevated bilirubin that's also developing. Furthermore, it doesn't seem like there's any signs of nausea or itching. The ostomy is still functioning as normal, and it seems like there's some clearly defined scleral icterus and generalized jaundice, which is consistent with her elevated bilirubin levels. Furthermore, the abdominal exam is unremarkable. There's no palpable tenderness, there's no organomegaly, there's nothing that's concerning about the abdominal exam, and then the central line looks like it's clean and intact. So again, less likely infection. So all we have here is basically somebody who has been limited in their oral intake, receiving primarily nutrition by the TPN. Sorry, if you couldn't see the highlights now, you're able to see them. But essentially having low oral intake, receiving nutritional needs being met by the TPN, and now they're having this elevated bilirubin and some jaundice. And so what is going on here? And so this is essentially known as cholestatic hepatic disease. And it's a very subtle presentation that's common in patients who are on TPN and cannot have enough intake by mouth. So what you see is on labs, which are not included here, is that they'll have an elevated alk phos. They will have this elevated bilirubin, which results in the jaundice that you see on physical exam. Okay, and then likely you'll see minimal rise in their LFTs. So LFTs will be unremarkable. So if you're thinking of some kind of cholecystitis kind of a picture, any kind of common bile duct obstruction, you won't see that kind of a pain presentation either. So typically there will be no abdominal pain in this condition either. And so what is the treatment for this? You're going to basically stop the TPN and try to introduce more enteral feeding. And this is essentially cholestatic hepatic disease. So D is the correct answer here.